Good day, everybody. Thank you so much for taking the time to join us on this webinar. The specific focus of this webinar is hospitals. We know that they've been at the forefront of the response in many countries and have had to adapt to the changing situation and meet a very specific need. So we have some exciting people here with us on the call today to share their experiences, their wisdom and their knowledge. And we're very thankful that they've been able to take time out of their very busy schedules to be with us here. We're recording the webinar, so the recording will be available after we have finished, and we will be able to share that with all who are on the line. But first and foremost, I'd like to hand over to my director, Dr. Sylvie Briand. We're trying to maintain some distance.
Difficult.
Sylvie.
Yeah, okay. Good morning or good afternoon, everyone. Thank you very much to the presenters who have been asked at a very short notice to participate in this call. And just to highlight what Sarah already said, that it's very important in this pandemic to get insight on the experience in the field because it's a new disease. I mean, we are discovering every day a little bit more about this disease and this virus, and somehow everybody has to adapt to this new knowledge, but also to the feature of this pandemic. And so we think that we will be able, as humanity, to respond to this crisis much better if we share our experience. And that we can collectively learn from this very rapidly. So this is the aim of this call, to see from different countries in the world. Namely, we have Singapore, South Korea, and from Hong Kong as well. What have been their experience and what have been the challenges that were faced, and what are the innovative solutions they have developed to be able to better respond to this health crisis. So I will hand over back to Sarah, but really a big thanks to all of you for being there today and to help us to increase our knowledge on hospitals and COVID-19. Thank you very much. Bye.
Thank you, Sylvie. So first of all, I would like to hand the floor to Professor David Hui, who is a professor of respiratory medicine and the director of the Stanley Ho Center for Emerging Infectious Diseases at the Chinese University of Hong Kong. I will stop my video and I will allow Dr. Hui to share his screen, and I believe he has some slides as well. Dr. Hui, over to you.
I need to upload my slides.
It's okay, we can hear you well.
I think the computer indicates the host has disabled participant screen sharing.
All right, let me try something to enable that. Apologies for that. Can you try again now?
Okay.
Great, we can see your screen.
Oh, okay, that's good. Can you see the full screen?
Yes, we're on a. Yes, we can see the full screen now. Thank you.
Good. So I'll give an introduction to the epidemiology and hospital control in Hong Kong. So as of today, we have 1,030 cases. And you can see that at the moment, 8 patients are still in intensive care. 5 are labeled as serious. That means they are requiring at least 3 liters of oxygen on the ward. We have discharged 674 patients, but there are still many patients who are still positive on the respiratory samples waiting to be discharged. And so far, 4 patients have died. And you can see the epidemic curve that the initial cases labeled in blue came from Wuhan, and then resulting in some local community transmission. And then recently, the cases mainly returned from the Hong Kong citizens returning from Europe and North America, and they have been confirmed COVID-19. So this is the information. So the majority of cases have been imported to Hong Kong. And interestingly, we noticed that out of the 1,000 cases in Hong Kong, 18% are actually asymptomatic. And they are picked up because of the enhanced laboratory surveillance that all the people who arrive in Hong Kong, all the Hong Kong citizens and travelers, they are actually being tested. So quite a high proportion being asymptomatic. So far, we don't have any nosocomial transmission. There are 4 healthcare workers being confirmed with COVID-19, but 3 actually returned from overseas trips, and 1 actually occurred in the community setting. So far, there has been no nosocomial transmission. The length of stay is quite variable. It is between 2 to 53 days, with a median of 16 days. There are still quite a lot of patients who are clinically well, and yet the PCR are still positive on one day, negative the next day, and then positive the third day. So you can see that we are quite fortunate that we don't have a lot of ill patients. So this is the table summarizing the cases. So far, only 27 have ever required intensive care support, either for ventilatory support or ECMO or in shock. And about 22 patients have required supplemental O2 3 liters or more on the ward. And you can see that the majority, about 77%, are actually very mild, and about 18% being asymptomatic. Now, we learned the mistake from SARS that at the time in 2003, our medical wards were very overcrowded with poor ventilation, and there were only curtains in between beds, no proper isolation rooms. But fortunately, the government actually has injected a lot of funding, building a lot of negative pressure isolation rooms as from 2005. So at the moment, we have 1,400 beds with double door negative pressure and a minimum of 12 air changes. And they are actually in the combination of either 1 bed, 2 beds, or 4 beds. And they are scattered in 14 acute hospitals. And we are using the single rooms for managing the suspected cases and also the newly confirmed cases because they have high viral load. And recently, the hospital authority has also converted general wards to negative pressure isolation wards with 12 air changes per hour and installation of HEPA filter. This is only tier 2 because they only have single door. They don't have double door. But this sort of ward would be suitable to step down the stable patients. So that means they have no fever, no need for supplemental O2 with radiographic improvement. And yet they still have positive PCR with very high CT values. So they're just waiting to turn negative before they can be discharged. For the inpatients, we are testing nasopharyngeal swab and also throat swab. And you can see the work from Dr. Malik PR is that the nasal swab viral load is usually higher than the throat swab. But even asymptomatic person, the viral load can be as high as those who are symptomatic. So we cannot ignore this asymptomatic population. So currently in Hong Kong, we are still isolating them in the double door negative pressure isolation rooms. Now for the close contacts and travelers who came back from overseas, we are relying on deep throat saliva to monitor them. And this is because it does not require any isolation room facilities. And we just give them the specimen bottles, and they can actually spit out the deep throat saliva. And currently we are collecting 2 specimens during the 14-day quarantine period. So they collect 1 on arrival, and then we collect a second one on day 12 to make sure we do not miss anyone who turned positive late during the incubation period. And you can see the work from Professor EPI-WIN that the viral load from the deep throat saliva is actually quite good. It is about 2 log lower than the nasal pharyngeal specimen, but still it is a very convenient way to collect specimen to monitor the close contact and traveler, so that we can actually protect the hospital A&E so that they don't need to provide this sort of service for the close contacts. The deep throat saliva is also quite typical. You can see the viral load going up to a peak around day 2 to 3 and then came down slowly. In Hong Kong, we have enhanced laboratory surveillance. So we have tested a lot of patients through the A&E hospital and also the government outpatient clinic, private clinic, and even the inbound travelers who are not symptomatic. We are still doing the test, and you can see we pick up quite a number of cases on the right-hand side here. And the private hospital are also helping us to collect the specimen from the outpatients. The testing capacity in Hong Kong is actually very high, and we are only second to New York State and also Germany. And we believe that the more tests we can perform, the more patients we can pick up, and the more we can actually protect the hospital systems and also the community. For the treatment, we are actually using Calitra, ribavirin plus or minus subcutaneous beta interferon, based on data from treatment of SARS and also MERS on the marmoset model. We are also taking part in the Gilead remdesivir open label RCT, and we have recruited more than 30 subjects for the Gilead studies. We are still in the containment phase and using containment measures. So we rapidly isolate the suspected case and the confirmed cases, and we quarantine all the close contacts and Hong Kong citizens who return from overseas for 14 days. All the mass gathering events have been canceled, school closure since January, and remote working for the civil servants. And we have continued to proceed with enhanced laboratory surveillance. The general public actually wear surgical masks in the public areas and crowded areas, and also paying attention to hand hygiene. We also have a lot of social distancing measures in the restaurants, including hospital restaurants. We have tables separated wide apart, and also there are plastic boards separating the tables. And all the entertainment business has been suspended. So the challenges that I can see in Hong Kong, we have a lot of patients with persistently positive PCR occupying our hospital beds. And there are also a lot of patients with asymptomatic infection, and they still have the potential to transmit the infection to others. So currently we are relying on the cocktail therapy, Calitra, ribavirin, and beta interferon, and we are also taking part in the remdesivir trial. There is some concern with PPE supply, especially with the N95 mask, but recently the mainland factories have resumed activities and service. So the supply seems to be not so bad these days. We have suspended all the non-essential clinical service, and this hopefully will gradually resume as the number of cases is coming down. And the general public actually has some fatigue with the social distancing measures. Thank you for your attention.
Thank you so much for sharing that interesting presentation with us. I think what we'll do is we will go to the next speakers, and then we can come back at the end to some questions. I'd like to hand over now to Professor Ye-Jean Kim, who is a professor in the Division of Infectious Diseases and Immunodeficiency of the Department of Pediatrics of the Samsung Medical Center at the Sungkyun Kwan University School of Medicine in Seoul, South Korea. Professor Ye-Jean, over to you.
Thank you for the introduction. I would like to share the slides. It's a little bit different from what David presented. I'll just briefly introduce some epidemiology of Korean situation, and then I will focus on what we do in our hospital, because I think the topic of this is also what you do in your hospital. to prepare and to take care of the patient as well. So I would like to show what we do in our hospital and before and during this outbreak as well. Okay.
Thank you so much.
And I got some slides from one of my colleagues, and I had I made some slides together. So the slide is a little bit quick made one, so apologies for that. How do I do this?
There should be an option at the bottom to, oh, yes. I think we can see now that.
Yeah. Do you see it now?
Yes, we see your screen. Thank
okay,
you.
Good. So this shows the timeline of COVID in Korea as of March, and on March 2nd, which when we summarize a bit in the beginning. So we had a first case of COVID patient in January, and then that person was coming from China. And then we had the government raised the alert level from blue to yellow, and then yellow to orange. And at the time, WHO declared the PHEIC. We started as of February 4th. The government started early restriction for those coming from Hubei. And then we also did PCR tests become available. During this time, only the PCR was available through Korean CDC, but then we started the PCR available in other laboratories in Korea, in 46 laboratories in Korea. So no new patient for 2 days, but then we have this very significant patient on February 16, the patient 29, the first patient without epidemiologic link. And this was an alarm to us. But then 2 days later, on February 18th, we have one patient, patient 31. Later, we found that this patient actually was related to all this religious group, massive surge and outbreak in Daegu area. And one of my colleagues, Dr. Chang, will describe what she experienced during in the beginning and during this outbreak in Daegu at Gyeongbuk National University Hospital. And we also have then first pediatric case. So you see the first imported case and then first no epidemiologic link patient, and then you also have a patient with a massive epidemiologic link potentially, and also you have a pediatric case at this point. And we have also first mortality case on February 20th. So about 1 month, what happened this. And at this point, the Korean government raised the alert level from orange to red, and they delayed the school school opening by 1 week, because typically in Korean situation, we start new school years on March the 2nd, and it's 1 week before the March the 2nd almost, and they delayed the school and school opening. And they also now have early restrictions, entry restrictions for those coming from Korea. At the point, other countries also have this restrictions as well. And as of March 2nd, at that time, we have a total of 4,000, 1.5 months or 4,000 deaths, 22 patients, fatal cases, and delayed new school year another 3 weeks. That's what we happened. And as you already heard from many report and news about this religious group massive outbreak, and that led a massive outbreak in Korea. And then that was March, and now April the 21st. This is what I got from our Korea CDC English website, and the total number of Korean confirmed confirmed cases in Korea is now over 10,000, and over 8,200 people are discharged from the isolation, and about 2,233 people are either in the hospital, hospitalized patient, or actually in out of hospital isolation and care center. So we do not let people confirm the cases, confirm the patients stay home, because there's still a possibility they transmit the virus to other family members also. So we try to do our best to, so with any risks for progression, we hospitalize them, but also very mild, young, healthy, no underlying illness people, they go to this special center. We call it Life Treatment Center or Living Treatment Center by Korea CDC, and it's a accommodation facilities by local government or by some companies, all that, and it's a training center and accommodation facilities which has individual rooms and also with bathroom inside. So all these people are staying in this single room unit, and then they get regularly monitored for their symptoms and regularly regularly follow up with the PCR test. And then when they are become negative 2 times in a row, apart 24 hours, and then they can go home. And it's really, by the way, they shed virus for a long time, and really many of the people are actually positive beyond 3 weeks, 4 weeks, and 5 weeks. So it's a virus that really needs a patience from us to see the test, to see a negative test. Anyway, that's the situation here in Korea. And the case fatality rate, as you can see here, we have disease. Unfortunately, 237 patients died during this outbreak so far, and that gives us the case fatality rate of 2.2%. It was lowish, but then now it's about 2%. And mostly, as you can have many, you already experience in your country, and older people have more higher case fatality. And in our country, about 70 or 80, 60, those people, reaching like 30%, 40%, something like that. But younger people, so we have no deaths so far, people age under 20. And we have also this issue of become negative and positive issues, and it's really lots of a debating situation there. And Korea CDC are working diligently to figure out what's going on in these people and why they are becoming positive. The virus, again, positive again virus, are they infectious? Are they culturable? Do they have immune response despite this prolonged shedding of virus? All those things are being investigated at the moment. So I hope we get more data in the future. So far, as I hear, some viruses already tested, and so far none positive from this patient who were negative and positive again. And when do they become positive again? Average about 13 days or something. Actually it's anywhere between day 1 and day 35. It's a very wide range of days. However, within most people, within 2 weeks, they become positive again. And if I want to talk about these new cases so far for the last 2 weeks in Korea now, it's mostly imported cases. So about 57 patients are imported cases in hospitals, nursing homes, and local clusters. And still we have this religious group linked and also people who were exposed to imported cases. All those things are the situation for the newly diagnosed cases. And then I want to share you what I experienced in our hospitals. I'm coming from Samsung Medical Center, and I got this slides from my colleagues, Dr. Ji-won Kim, and also from infectious disease response team, Dr. Dr. Joe, and others as well. So just a brief introduction about our hospital. It's a urban tertiary quaternary care hospital, almost 2,000 inpatient bed and more than 50 operation rooms and almost 200 ICU beds. And we have lots of outpatient visitors, and as well as we have many healthcare workers, almost 8,000 healthcare workers in our hospital working. And we have activation of we activated the response system after we have this first case of COVID-19 positive patient, the risk management committee for the speedy and transparent communication channel. And we also transformed some facilities to further care of the patient, future patient, and also suspected patient. And we use lots of IT technology and for screening and managing patient and visitors, and also screening and managing employees. In fact, I get every day two messages that I need to answer. So they actually ask me whether my temperature, body temperature, and some symptoms, there's 5 or 6 symptoms, typical symptoms, and I have to punch the button no, and I put my body temperature number, and then it goes back to the central database. So they monitor every healthcare worker's morning and afternoon symptoms. And we also have triage and patient flow management as well here. So our CEO, the Professor Kwan, and we have infectious disease response center, to making all the recommendation and stuff. And also for execution, we have a crisis response team and clinical area, strategy, operation, resources, logistics, communication, IT development, and human resources. All these people have meetings weekly or sometimes twice a week. And we also have everybody's meeting once in a while. But I try not to have too many meetings during this time. So hospital-wide announcement, you have unit-specific guidelines. So for example, I'm a pediatrician. For pediatrician, there's pediatric issues, very specific pediatric issues, urgent delivery, and this delivering mom, the woman has a fever, certain fever, and what would you do? And you have to have this as delivery room, and the baby potentially, she has to be tested for COVID, but then what would you do for the babies until the test becomes, test results become available? Those kind of very specific guidelines or specific guidelines for surgery and anesthesiology, all those things, or ER. So hospital-wide announcement and unit-specific guidelines also. And also we get feedback from individual units for all the stuff. And this probably what you do all in your hospitals as well. So we have call centers. So when they have questions, we call the call center. And there are infection prevention nurses and the people from the offices that I can answer, and also all the logistic issues, and also sometimes emergency patient care issues and everything. And we put up an outdoor triage area because your ER is filled with people. This is our ER triage, and we have a negative flow pressured room also inside there, but you cannot hold everybody. Sometimes this ER triage, you have to have a very long hours. So and you have to actually find who is really an urgent patient. So that's really an issue. And we have this communicable disease isolation units. And also we have this COVID-19 laboratory. We set up early February, and we do, I think, 8 times a day or 24/7, and everybody is doing the PCR, the laboratory personnel. So some of the laboratory personnel are only focusing on this test, and it's real time, 24 hours, all around the clock test results are available. So we have also to transform, and we have to actually have to control the traffic as well, because you have lots of in and out flow of people. So we have main building, annex building, and cancer center. We have lots of gates, and we actually close the gates, and we only have some gates opened. And at the gate, we actually check everybody for entering. So screening all entrance by thermal images and individual temperature measurements and survey for symptoms of travel. And in the beginning, have you been to China? Have you been to Wuhan? But now we have lots of outbreak clusters in Korea as well. But have you been to city such and such? Have you been to hospital such and such? All those questions, long list. So these lists should be updated by the infection preventionist and the infectious disease response team as well. And universal mask wearing. So in the beginning, we handed out all the masks from the hospital, but as time went by, you know, the masks became very precious. So we couldn't do the giving out the mask anymore. So everybody who entered the hospital building, they wear the mask from their home. And nowadays, you know, in Korea, you can buy the mask. So depending on which, I think, which day or year you're born, you can go to the pharmacy, and you know, so for example, like I need to go to pharmacy to buy a mask. I go to pharmacy on Wednesday, something like that. So everybody has their day to go with their identification number, so that, and then hand sanitizer at the gate so they can enter. And sometimes even with this, they go through, but then at waiting room, they develop fever. So that kind of thing can also happen as well. But in that situation, also we have a backup plan, and they can go to the symptomatic clinic, and then they can be tested, and they can be examined again. And the use of apps. So for this, we do a mobile online questionnaire prior to schedule the visit for the patients and visitors. So, you know, when you have a scheduled appointment for the doctors, and we automatically send out the text to let them know their date and where to go. However, with that, in addition to that, we now have this screening stuff. So we send them the messages, and, you know, are you having some symptoms, or you have any history for visiting such and such place? Those things are pre-screened before they come to our hospital as well. And also they have, this is like, you ask their date of birth, and you ask their symptoms and fever, things like that. And use of apps. Also in our hospitals, we do know, we actually put some notes on the patient. So if the patient has symptoms in relation contact with epidemic event, we have red ones. They need to be asked about this in COVID. And they have an epidemic link, but no symptoms, and then orange. And no relation context, and no symptom, green. And no survey, something like this. So we can actually know who is with red, who is with orange, all the steps, all the patients who are visiting us or in the hospital, we can do that. And also we ask the questions to the patients as well at the entry, at ER, this questionnaire about their risk for having a COVID. And this is also, it's a national level stuff. It's a drug utilization review. So if you have any overseas travel history or any of those, so for example, somebody who is coming from Wuhan in the beginning of February, so all this information coming from the airport, they go to the drug utilization review system, and they will send you the information to your hospital. And if you actually open your computer to see open the patient's electronic medical record, it'll give you the pop-up, oh, this patient has a risk for COVID, something like that. So this been actually designed from 2015-ish, when we had this massive MERS outbreak in Korea. And that was a very hard, difficult lesson we learned. And we learned a lot from that experience. And this has been used since then. And this time also, we are using it really efficiently as well. And not just for travel history, but also we have this massive cluster outbreak. Those things also can be linked to this system as well. So for employees, this is the one that they ask me this question every day. So this is the screen that I see every day, twice a day, and I have to see, and I have to answer the questions as well. And if we have, you know, so some symptoms, that'll be really disastrous, because, or if we have infection, because we can be the source for further transmission in the hospital outbreak. So having a healthy, no infection issues among healthcare workers and employees are very important. So we have this universal mask wearing and silent side by side sitting only meal campaign. So in fact, this, like Dr. David mentioned, in our hospital cafeteria as well. So you're not allowed to talk. You can only eat. So that's very sad, but this is what we do in our hospital cafeteria as well. And this shows the triage and patient flow in our hospital. So we have this the clinic here. So that they come in and they wait and they do the test, and patient the healthcare workers moves around this way. This were for symptomatic people, this for asymptomatic people, things like that. And triage and patient flow. For outpatient visit, if it is not too urgent, we postpone non-urgent visit. And also we do the telephone consultation for medical refills. Also, we try to minimize wait time in the waiting area because, worry about the transmission in waiting area as well. And in patient management, postpone elective procedures and surgeries if it is not that necessary urgently. And patient admission in the hospital. So if they are coming from certain areas, so during this outbreak in Daegu, we were screening everybody who were coming from Daegu and make sure they are PCR negative as well. And also when we have lots of referrals from all over the countries, and we do the test before they come to us. And if they have any respiratory symptoms or fevers and anything during the hospitalization, we do the test again. And here also X-ray and other stuff as well. And safety check around the team. So the team members go around every corners of a hospital, and they reassess the risk and for safety issues and do the modification as well. Thank you.
Professor Yejan, thank you so much for sharing all this information. It's a huge amount of information that I'm sure will be very well received and relevant to many different settings. I'd like to hand over now to your colleague, Dr. Chang, because I believe that you'd like to share some of the experience that you had as an infectious disease physician in Daegu. Dr. Chang, over to you.
Can you hear my voice?
I can hear you, yes.
Yes.
Would you like to, are you going to share some slides or?
I'm sorry, I needed some time.
No problem. We can use the time to digest all the information. To the participants on the call, I believe we are getting some questions that are coming through on the Q&A. So if you do have a specific panelist that you'd like to address your question to, please do make sure that you indicate that in the question. Hopefully we will have some time for the Q&A, but if not, we will definitely discuss how to best follow up after this webinar. Dr. Chang, are you able to find the share screen?
Yeah, I find the screen. Yeah.
Perhaps if you require a little more time, we could go to Dr. Sophia and then come back to you. Would that be helpful?
Please wait just 60 seconds. Dr. Kim Yoo-jin, please, can you play my my
Yes,
presentation?
maybe I can share
I'm
the
so
slides
sorry.
from my side. Can you send the slide to me then?
Okay,
I'm very sorry. Yeah, I have to postpone my presentations. Yeah, to the next stage maybe.
okay, great. No problem at all. We'll go to Dr. Sophia Archuleta, who, and I apologize if I say your name incorrectly. Dr. Sophia is a head and senior consultant and associate professor in the Department of Medicine of the Yongloo Lin School of Medicine at the National University of Singapore. Dr. Sophia, thank you so much. Welcome to the call, and over to you now.
Thank you so much, Sarah. Would it be all right? I'm just going to share a screen from our Ministry of Health, and then actually, if it's all right, I could turn on my video because I came without slides, ready to talk practicalities with the rest of the group. So let me do first the screenshot. Yep. Share screen.
Thank you. We're very receptive to videos, and this, as webinars are now the new normal way of working. We're getting used to everybody.
Wonderful, thank you. Can everybody see this? I think you should be seeing something that says COVID-19 situation report on your screen.
We see it, thank you.
Yeah, excellent. So this is just a snapshot of what's happening in Singapore. I'll just flash it for a second because clearly it forms the background to our hospital response. Maybe I'll draw your attention to the EPI curves. On the top is the total cases that we've had in Singapore, which is around 9,000 cases. I'm sure we'll hit 10,000 today at the rate things are going. This is our community spread. In green are work permit holders in Singapore. In blue is where you'll see our current, the current problem we're facing, which is outbreak of COVID in congregate settings, specifically in our dormitory residents, where a lot of the foreign and migrant workers in Singapore stay. And then on the bottom in the red, you see the imported cases. So similar to what my colleagues from South Korea and Hong Kong described, our first case was January 23rd. It was imported in travelers from Wuhan, from China. Right now, if you look, you'd have to squint to even pick out that first wave of imported cases back here in January and February, which occurred from those travelers and around the time of the Lunar New Year. Then we saw a second wave of imported cases around the time that people returned to Singapore, so from the US and UK primarily, but thanks to stay-home notices and quarantine orders for those travelers, essentially we have 0 imported cases at this point. Community transmission followed very closely the first wave of imported cases, and then the second wave, and was commensurate in how big it was. Currently, Singapore has implemented for the past 3 weeks its equivalent of a lockdown, something we call the circuit breaker, which involves more significant closures of public events, schools, and social distancing measures. And our community spread has plateaued and is coming down nicely. And again, what that leaves us with is this big wave of cases that we're seeing in the congregate settings of the in the dormitories of the foreign workers, and is our current struggle in how to meet that demand, both in terms of the hospital beds and also the EPI work, identification of cases, isolation, and contact tracing. And that's really all I wanted to show. Let me go back to stop share, right? And then I can turn on my video. Okay, hi everybody. Yep, so I'm Sophia from Singapore. I think the perspective that I wanted to share with everyone was that of an infectious diseases division and a hospital that is a tertiary and quaternary care hospital. That's the National University Hospital here in Singapore. We're a 1,200 bed hospital, and we are very busy clinically on a regular day, including tertiary and quaternary care services, transplant, immunocompromised hosts, and including a very busy and active academic portfolio with research activities and education. And I'm pretty sure there's a few people on this call who face similar busy and schedules and have to multitask with all these portfolios. When we had our first cases in January, it was no surprise. The hospital was quite well prepared. Again, similar to our colleagues in Hong Kong and South Korea, we had past experience. So SARS was obviously a very much a defining moment in terms of public health response in Singapore. Isolation capacities, public health infrastructure was strengthened very much from the lessons learned at the time, and that includes our hospital. So there has been infectious disease outbreak drills and preparedness that have been going on a regular basis since that time, and our isolation capabilities in terms of infrastructure have been very much beefed up since that time. But at the same time, it's a very different situation that we're facing now. In our hospital, we've had over 300 cases at this point that have been managed. About 10 have been in intensive care. We've had 2 patients on ECMO and no deaths at this point. Nationally in Singapore, there's been 11 deaths. So the case fatality rate in Singapore is quite low at 0.1%, reflecting the fact that for now, it's a relatively young population that has become infected. In terms of how we responded at the hospital, and I think it's worth, especially for people who perhaps are from regions where it's relatively early on, or you have a lead time to get ready for when the COVID cases start to hit, is thinking about the strategy that you're gonna adopt in the hospital. For us, it was in line with the national approach, which was testing at a large scale, detecting cases, isolating, and contact tracing to shut down clusters. So in line with that, we made sure that our isolation capacity was scaled up. We did that by decanting wards that have single rooms, whether they be negative pressure or neutral pressure. We've used all that were available to us. And that was done, again, very early on, but the strategy had to change as the cases increased. So we have now moved from seeing a lot of suspect cases that required single rooms to having increasingly more positive confirmed COVID cases. So we've actually implemented cohorting of positives in natural ventilation wards. So we have currently in our hospital over 100 patients in those naturally ventilated wards, each one having 30 plus beds where the patients are in cubicles with shared bathrooms. And of course, proper precautions and flow of staff with donning and doffing areas. In terms of screening who comes into the hospital, that was also a very big priority for us. We wanted to ensure zero nosocomial transmission. That was a target from the very beginning, again, informed by hard lessons from SARS, where nosocomial transmission was seen, and there was colleagues that were infected and affected by SARS at the time. So this was a very important target for the hospital to set. So there is very close screening of visitors and patients coming into the hospital for other appointments, very similar to what our colleague from South Korea, Dr. Kim, presented. So I won't go into any details about that. Maybe I'll talk a little bit about how we screened symptomatic patients coming into the hospital. So again, in line with keeping the hospital safe, my priority was to, even at the time where the cases were only imported, we knew it was just a matter of time before we saw local transmission, but we adopted a policy that anybody coming in with signs or symptoms of an acute respiratory illness or ARI was immediately isolated and then investigated for COVID infection. That allowed us to stay ahead of the curve. I think others may have noticed the same, is that the ministry or EPI case definitions will lag behind to what is actually happening in the community. We saw that again during this second wave of cases in the foreign worker dormitories, whereas the prevalence in those dormitories has gone up. We do see a fair number of asymptomatic patients. So in line with that, then we move from not just isolating people with ARI, but in this specific population that has high prevalence, we are also isolating regardless of ARI symptoms and ruling out COVID in those cases before allowing them to go into our general wards out of isolation. So I think it's important to consider the screening strategy that each individual hospital is going to adopt, and whether that's in line with the national policy. That's also important in the flow of patients through the hospital. So again, similar to what our colleagues presented, we do not de-isolate patients in Singapore unless they have 2 negative PCRs 24 hours apart, along with clinical improvement. That doesn't mean the patient has to stay in the acute care setting. They can move to what are called community isolation facilities, or CIF. So they stay there. These are the walking well patients who are just waiting for clearance of the virus. However, as the EPI curve took a steep rise recently over the past 3 weeks, the capacity in the CIFs has not increased at the rate that we need to decant the people who are coming into the acute hospital. So that's another challenge, I think, for people to consider. And that's where looking for ways that you can increase your capacity to hold the patients in the hospital, whether it's in cohorted wards or other areas, that's important. Another challenge that we faced, another phenomenon that I think others are facing, is the rapid change in terms of guidelines and communications. We have meetings from morning to night, emails from morning to night, and the types of communications that need to be filtered and how best to communicate to all stakeholders I think needs to be considered for each setting. So for us, what we found very helpful was how to meet not just the information gap for our colleagues in other parts of the hospital and in terms of the leadership and strategic response to the hospital, but also the anxiety that people have in the face of a lot of uncertainty and the changing workflows. So one thing that we found very useful is we implemented a 24-hour COVID consultant hotline that ID consultants or attendings in the hospital take turns staffing, and it's been a way to ensure that our colleagues feel that they can always reach us in a way that perhaps with the emails and the structured meetings may not be enough in these uncertain times. And I think I can stop here, I know in the interest of time. And Sarah, I'm not sure if you want to pass it back to Dr. Chang, or we can do questions.
Sure, let's, thank you so much for sharing with us. Dr. Chang, we can pass back to you now. I believe Professor Yejan will share her screen, and you can speak to the slide on Professor Yejan's screen. Over to you now. Yejan, are you? Oh, we can see your screen now.
Thank you very much. Yeah, it's the short story about my some experience. Yeah, my name is Dr. Chang, and I am the infectious disease physician. Yeah. My workplace is. Can you play the next slide? Yeah, my workplace is 930 beds university hospital with a national government designated negative pressure isolation ward. There was 5 beds in one ward and 2 beds in emergency department. Yeah, and the date, January 24th, was the starting point of the rush of patients under investigation, especially people who returned from China to triage at emergency department. Yes, so the infection control team was activated at that time, even in the the starting day of the long holiday. All PCR investigation at that time was done through KCDC, and so the turnaround time was about 6 to 12 hours. Next slide, please. Yeah, the day, yeah, February 18th, yeah, in Daegu, yeah, on the morning, patient number 31, yeah, was diagnosed at Community Health Center triage in Daegu. After that event, we had to deal with the huge surge of suspected cases and confirmed patient at triage at our emergency department and isolation ward. But in the afternoon, we found the 3 COVID-19 patients at emergency department and general ward at the same day. Yeah, one was on the emergency department because of aspiration pneumonia, and two was in the general ward because of diarrhea, and one was mimicking acute pyelonephritis. They had no travel history, and all were related directly or indirectly to the one religious group. Yeah, next slide. Yeah, yeah. From the 9 p.m. From the 9 p.m. on February 18th to 6 a.m. of the next day, yeah, exposure of over 30 inpatients in 3 wards, 1 emergency department, and 2 medical wards. Yeah, we had to rearrange the room of the inpatients. Yeah, immediately we discharged a significant number of patients whose condition was stable to go home from other general wards, yeah, to prepare rooms for patient and healthcare worker isolation who were exposed in an individual room respectively, and to prepare nursing staff to care some confirmed or suspected patients, and all was done over just one night. It was a really, really miserable day. And the next slide, yeah, February 19, yeah, the next, the hospital management group sent a message to all healthcare workers to notify the occurrence of COVID-19 patients in our hospital and asked preparedness for prevention of nosocomial COVID-19 outbreak. All medical students was expelled from the hospital, and all staffs working in the 2 contact wards and emergency department required to have personal protective equipment with 5 items: head cap, goggle or face shield, N95 mask, and surgical gloves, and vinyl apron or surgical gown. On the same day, I can't remember the exact number of isolated patients and patient guardians at that time, but the number was over 90, including medical students and healthcare workers contacting index patients. The post-PCR test to them, including medical staffs of those wards, were done irrespective of the symptoms. Among the isolated persons, 2 patients were positive after 3 and 4 days after exposure. These 2 patients' bed was just right and left to the bed of index patient. Yeah, the most important thing in the infection control is the timely and accurate test result, of course. So yeah, from the late February, yeah, to get the test result of the COVID-19 more rapidly, yeah, we were expecting to get the lab result within 3 to 4 hours. We set up the in-house PCR laboratory in separated space in hospital and running 6 times of PCR test every day until now. Yeah, we already had enough number of mechanical ventilators according to the room capacity. Yeah. However, starting management of the severe patient in general ward, we found more patients needed the oxygen therapy through high flow nasal cannula. Government offered more high flow nasal cannula system to hospitals in Daegu according to the number of available rooms for COVID-19 patients in each hospital. Of course, every day, all medical staffs had a very stressful time due to the shortage of PPE, including N95 mask and PAPR and hose. Thankfully, other cities gave us the priority to buy the PPE, so it was possible to secure enough supplies of PPE. I really appreciate it. And we already had 2 negative pressure isolation rooms in emergency department. However, we had to increase the number of rooms up to 5 for isolation of increasing patient under investigation in the late February, and up to 12 before the March through remodeling. It took just only 3 days for remodeling. We had only 5 negative pressure isolation rooms in general ward, but it was not enough at all. Yeah, as you know. Yes, so therefore, yeah, hospital started remodeling construction of 2 medical wards and 2 ICUs to make more temporary negative pressure isolation rooms up to 32 beds in 2 medical wards and 12 beds, extra 12 beds in 2 ICUs. Yeah, it also took 5 days. It is one of the mission impossible for us. Yeah. For preparedness for the possible shortage of ICU beds, dialysis equipment for hemodialysis, and oxygen supply devices accepting mechanical ventilation in general wards were provided in the majority of the isolation rooms through this reconstruction. So we can offer the proper management to the hemodialysis patient even in the general ward. Yeah, to protect our healthcare workers in hospitals. Yeah, we didn't have any restrictions for healthcare workers in our hospitals to get the test for COVID-19. We have been running the specialized outpatient clinic for healthcare workers who wanted to get the PCR result. Yes, so during the working time from Monday to Friday, yeah, even for asymptomatic healthcare workers without any charge. Yeah, that outpatient clinic was operated by the Department of Family Medicine. For the healthcare workers who have any symptoms, hospital recommended staying at home with self-isolation before visiting the specialized outpatient clinic for healthcare workers to test PCR. Hospital leadership and management group did their very best and used every connection and communication to get a hold of any PPE, including N95 mask and hose for PAPR. Finally, we could escape from the serious challenge of PPE shortage, and now, because of the reduction of some patient, yeah, we also have some impatient until now, but yeah, we are in the some stable stages. So I really appreciate the all persons involved in this process. Thank you very much.
Thank you so much, Dr. Chang, for sharing your presentation and slides with us. We have some questions that have come through on the Q&A, and I believe that some of them are being answered live. It would be great to capture some of those. So when we finish the webinar, we will be producing a report of this webinar in which we will capture the Q&A as well and make it available for everybody. I'd like to hand over now to Dr. Brian, who is going to make a few comments.
I will also ask a question, because as you know, in many countries, we have seen that up to 10% of healthcare workers were infected. Of course, not all those infections happened in the hospital, but sometimes at community level, but still it was quite a high proportion of healthcare workers infected. And so I would like to ask maybe David Hui, you said that you had no nosocomial infection. So can you share with the others your some advice that we can maybe amplify through our WHO channel to other countries? What are the things that people can do to prevent nosocomial infections?
Okay, thank you. We isolate the suspected case very early in the double door negative pressure isolation rooms. The healthcare workers, they are very good in dressing with the PPE, and also that they are very careful in degowning. We perform the laboratory test very early. And of course, at the A&E level, they are also very careful with the triaging. Because we don't have a lot of ill cases in the hospital, we decided that for those who require supplemental oxygen more than 5 liters per minute, we would actually transfer them to intensive care. And in case they deteriorate, they can be intubated electively. So we try to avoid the use of non-invasive ventilation or high-flow nasal cannula in the isolation rooms. And this is only because we don't have a large number of very ill cases, so we can afford to do this. Yeah. So I think all these measures would help. Yeah. And the healthcare workers also have learned a lot of the experience from SARS. So we have the habit of almost like universal masking in the hospital setting. So whenever we go for what round, even in the low risk area, we have been wearing a surgical mask for the last 17 years. And when we enter high risk ward, automatically we would upgrade to N95. So I think the healthcare workers' experience with wearing appropriate PPE is also very useful.
Thank you very much.
Thank you very much.
I'm aware that we're over time, but it would be good if we're able to capture a few more of the questions that have come through. So there's one for Dr. Yejan. What facilities are designated as care centers, and what is their main role, and what services are being provided there? Dr. Yejan, are you able to address the question?
Yes, this is Yejin. I am sorry that I do not have the exact number for the percentage of people who are hospitalized and who are in that life treatment center, just out of hospital isolation and care center. Mostly those people are on young age, like under 50, without underlying illness, and very, very mild or asymptomatic positives as well. And what they do there is actually they are staying during the entire isolation period in their unit, and they go to bathroom there, they stay there, and every day they have a meal delivery people. They deliver the meal box to their door, and then they get the meal box. And also they get at least in the centers that I know, and I think most centers, all the centers, they have those app, I show you the app, so they send the screening monitoring questionnaire to those isolated patients using an app, and they can answer their symptom, and they can answer their body temperature. And in that center, there are physicians and nurses dispatched from nearing hospitals and other hospitals, and they do that. If they have any serious symptoms, then they get transferred to the hospital, or designated to the hospital. So in the center that I have some information, so there were people who were discovered to be pregnant, and they immediately removed from this care center and went to the hospital. And also there were somebody who was complaining of chest pain, and because they don't do any chest x-ray there, because for the entry requirement, they should not have any chest abnormality. They should have normal oxygen saturation. They have normal chest x-rays. So they do not do any chest x-ray over that center to come in out of hospital isolation center. So if they have, if they complain of any unusual symptom, they go to the hospital. They are transferred to the hospital. All those things. But otherwise, you are actually just monitoring them. And they also have some guards, just in case. Some of in the news, there was one person who actually went out to the community and just walk around, and that has to be really prevented. So they have a guard, they have a medical team, physicians and nurses, and every couple of days, usually 2 times a week, they do the swabbing, the nasal swabbing. What they do is the nurse visit each individual room, and at the gate they do the swabbing, and then they get the sample and they do the test, all those things. And then when they have a negative PCR for 2 times with symptom improvement or continuously asymptomatic, they can go home. That's what they do in that out-of-hospital isolation care center. Over.
Thank you very much for your response. Sylvia,
Sure. And also,
yes, sorry.
There was a question about this DUR, drug utilization drug utilization system. So if I can show you more, just one slide to explain what it is for those who are not familiar with this system. Is it a good time for me to talk about?
Yes, please do.
Or later. Okay. So I can show you this. Let me see how I can.
If you make it full size, then we could.
Yeah, I wanted to do that. I think this, yes. So do you see now? Oh no, yes, this is the one. So I can show you what it is. So somebody, let's see, somebody arrives in Korea, and they have some information about you know, this travel in the Zika area, MERS area. In this case, COVID area, or everywhere is COVID now, but in the beginning, Ebola, whatever. And then they have this information sent to National Information System. It's thing in Korea, and every day, 2 times a day, 7:20 and 13:20. I don't know why it's 20, but it's 20. And then it goes to Health Insurance Review Agency, because in Korea we have everybody has this nationwide health insurance. So everybody is enrolled in that system. So I think that's why it is possible in Korea, particularly using this drug utilization review system. So this information goes there, and the information is processed over there, and they are linked with this drug utilization system, the drug utilization review system. It's usually it is used for, like, for example, fluoroquinolone. If fluoroquinolone is levofloxacin is about to prescribed in pediatric patient, they will see, oh, this is not approved for this age. That kind of monitoring. So, but in this case, they use this system to notify information of exposure, and this information goes to the physician's office. So when they open up the chart in computer at patient encounter, they can check the DOR. So there could be some time delay, but they actually work really diligently. So, you know, sometimes, you know, there's somebody who arrived at the airport and then directly goes to some ER. Maybe in that case, you cannot maybe capture that event, but most of the patients, they come, they land, and they stay, and then at some point they go to hospital situation. In those situations, they can capture the information of the exposure. This is what we do in our Korean system, this through drug utilization review system. Thank you.
Thank you very much. I'm aware that we have a number of questions that we've not been able to answer, but also that we have very busy people on the line who have taken time to be here, and for that we're extremely grateful. So I'm afraid we're probably going to draw this to a close now. I would like to extend a really large thank you to everybody who's taken the time to be here to share their knowledge. We will be able to share the recording of this webinar with those who've registered for the call. I'd just like to ask Sylvia if she has any closing remarks before we say goodbye.
I would like just to add my thanks to all of you. I think it was extremely interesting and also important. We have also, as WHO, webinars with other countries in Africa, in South America, and so thanks to your sharing of information, we are able probably to guide them a little bit better on how to tackle the COVID-19 health crisis. So obviously there are many differences between countries in terms of resources, buildings, capacities, etc. But any experience is really useful for other countries, because then they can address the situation better, but also faster than if they have to rediscover all of this at once. So I think your generosity in sharing your experience and your information is extremely appreciated, and thanks to all of the people who participating in this call and ask also a very pertinent question. Thank you.
Thank you very much. And I think we'll end the call now, and I wish everybody a safe rest of the day. Thank you for joining.